Good morning. Thank you for joining the Foundation for a Healthy Kentucky's Health for a Change webinar, APCD, the big picture. I'm Ashley Brower, Vice President of Communications for the Foundation. And today we're going to explore what an all-payer claims database, or an APCD, could mean for Kentucky. If you don't know exactly what that is yet, or you don't have a full understanding, that's okay, because that's exactly what we're here for. We are excited to have such a large panel of experts with us today, all ready to share their perspectives about APCDs. Our moderator today is Dr. John Langefeld from Insights for Health. Our panelists include Emily Beauregard, Executive Director of Kentucky Voices for Health, Jenny Goins, President and CEO of the Kentuckiana Health Collaborative, Dr. Stephen Hoagland, Chief Medical Officer of Kentucky Primary Care Association, Dr. Christopher Johnson, professor at the University of Louisville and Foundation for a Healthy Kentucky Endowed Chair, and Dr. Jeffrey Talbert, professor at the University of Kentucky. Before we get started, a little bit of housekeeping. We've enabled the live transcript feature on this webinar, and you can control whether you see the closed captioning by selecting live transcript on the bottom of your screen. We also invite any questions you may have. Just type them in the chat box and we'll address them during the Q&A portion. First, just to tell you a little bit about us, the Foundation for a Healthy Kentucky is a nonpartisan, nonprofit organization focused on access to healthcare and children's health. Much of what we do is in the policy realm, whether on the state level, local level, or even the school or organizational level. Our goal is for all of you to leave this webinar today with an understanding of these topics. What is an APCD and why does it matter? How data from an APCD can be utilized, and how they inform policy and research, how APCDs benefit employers, payers, care providers, and how they benefit patients and foster financial stewardship. For those of you that are coming into this without a lot of background on what an APCD is, we are now going to share a short video that gives a very high-level introduction of the topic.
APCDs are large state databases that include medical claims, pharmacy claims, dental claims, and eligibility and provider files collected from private and public payers. We know that's a lot to process. Don't worry, we'll explain more. Here's why APCDs matter. Clear information about our paid healthcare services is necessary to achieve better health, better quality, and lower the impact on Kentuckians' wallets. There's a lot we can learn from APCDs, including healthcare facilities' performances like infection rates and readmission rates, prevalence of opioid use in Kentucky as it relates to public and private pharmaceutical claims, health data by provider, region, incident cause, and prevalence, and population health reporting focused on state issues. Learn more at healthy-ky.org.
Now I'm going to turn things over to our moderator, Dr. John Langefeld. He's a longtime family physician from Kentucky who is particularly focused on how to use insights delivered from data. Dr. Langefeld.
We're really here to talk about some of the basic questions you may have. And if we look forward, we'll focus on what some of those basic questions are. And I think we begin, if you'll move to the next couple of slides, Ashley. In the next slide, we're really going to begin with a basic question, and that is why? Why is this important? And our why is to understand and work to improve health. And what is health? The definition put forward by the World Health Organization almost 80 years ago now is right here. Health is a state of complete physical, mental, and social well-being. It's not merely the absence of disease or infirmity. And as we think about that broad context for health, then what might it look like and how are we doing in Kentucky? And if we move to the next slide, then we see that the America's Health Rankings is just one of many statistics that are collected throughout the United States, but it's been collected for more than 30 years now. And what it does is collect the health statistics in states, and it compares states to each other. And what we see is in the last ranking, which actually came out last month, Kentucky ranked 43rd out of 50 states. And you can see some of our greatest challenges, things like drug overdose deaths and physical inactivity and dental care and chronic disease and obesity and adverse childhood events, premature death even. But the most disconcerting statistic is that over the 30 years you see in the graphic there, we haven't really moved the needle much in 30 years. And so how do we think about moving this in a more upward trend as we move forward? And if we look at the next slide, what we see that our vision for Kentucky's all payer claims database is to improve the health of Kentucky's children, families, communities, and workforce. And as we think about moving forward, let's think about a mental model, if you will, if you move to the next slide, of how this might work. If we broaden the lens just a little bit, some of the early work over 20 years ago, the Institute of Medicine published some of their seminal publications that really shined a spotlight on things like safety and quality and equity in healthcare. And it really created a national level of discussion and a lot of good work that actually began there. But if we move to the next slide, it really took us over a decade for us to take that work and actually devise and articulate a national quality strategy. And some of the early work of the Institute for Healthcare Improvement created what we now know as our national quality strategy, and it's referred to as the quadruple aim. And if we look at the quadruple aim, there's 4 primary components. One is, how do we improve the care and health for individuals? How do we improve the health of populations, whether that's a community or a state or a nation? How do we address the cost issues? And the cost issues, I refer to this as stewardship of limited resources. And then how do we lift up those who actually provide care for our communities and patients? And so the question then comes as, how are we doing with that? And if we go to the next slide, what we see is that, if you click it again, what we see is we still have people completely frustrated with their personal experiences and stress in our traditional care system. We've done little to improve our overall health metrics and populations. We haven't really addressed the cost issues at all. And we have epidemic levels of burnout in our providers and those who provide care for patients. So how do we think about this in a very practical way, and how might we move forward? And so I think we began, if we go to the next slide, I think we began with all of us as individuals. If we really want to think about a system that's focused, that's actually individual or patient-centric, if you will, if you click the next slide, we all live in an environment where we have a wonderful array of resources available to us. Now, unfortunately, some more than others, but you see them here. And it may be family, or it could be friends, or it could be our employer, or our government, or healthcare providers themselves, or transportation, or housing. But and all of these resources, even though they're there, if you go to click on the next slide, that's still within a whole constellation of touch points that are out there and potentially accessible. And each one of those touch points where we interact with that touch point creates data and information about what happened there. But unfortunately, that information or data that's created resides right there, and it's not shared more broadly. So we really can't get a sense of what the whole picture looks like for our individuals. And it reminds me of the example, if we go to the next slide, of that you probably know very well. If you have a group of people in the dark and they're all reaching out and touching something, and they're all trying to guess what it is, and all of their conclusions and assumptions are incorrect because they can't see the whole. So in today's world, if you go to the next slide, in today's world, what we have is an environment that's siloed, it's fragmented, it's mired in inertia, it's really not system-like. And so if we envision moving to something that is more system-like, that's interacting, interconnected, and interdependent, what might that look like? And I think a great example of this really is in nature itself. You think about nature itself. We as living organisms, and all living organisms, live in an environment that interacts in a wonderful interplay with our environment. And we call that an ecosystem. And so if we think about, if we go to the next slide, we think about what a health ecosystem might look like, where that wonderful interplay doesn't have hindrances, is a free interplay. And if you continue to click it, Ashley, a health ecosystem is also interacting, interconnected, and interdependent. And it really reflects the whole picture and doesn't have divisions and fragmentation that our traditional non-system might have. So as we go to the next slide, what we then want to think about is how do we begin to create this picture? And it all begins with data. And if you'll click through to the next slide, it all begins with data. And so let's think about where data comes from. And our work today and our focus today is on what we call the all payer claims database. And this data set is really in reference to what we call an administrative data set. Our world today in healthcare is a very transactional environment, meaning that every activity, interaction, lab test, et cetera, that occurs has associated with it a code. And that code is then submitted for generally reimbursement. So it's transactional. The fact that that occurs gives us one of the most robust views of not only what happens with individuals, but what happens across an entire population. So we call this a foundational data set, meaning that when you're going to construct something particularly big, you have to have a firm and wonderful foundation in which to begin. And so the all payer claims database is one of the foundational data sets that is required for us to make progress. It's not the only one that we'll eventually look for, because there are other data sets that can provide even more level of granularity and information. But we can't build the wonderful facility until we have the foundation. So that's where we are today. So if we move forward to the next slide, can we get to perfect data? And I'm a big believer in the adage that, you don't let perfect be the enemy of good. But what does perfect data look like? Because I think that's a good construct to keep top of mind. So perfect data has really two components. One is it's inclusive. It means that we have information about everyone, everywhere, in all settings. And it's longitudinal. We can view it across a period of time. It's instantly available. It's real time. And it provides both population and individual level detail. The second thing is it's accessible. It exists in a very sophisticated framework where we can collect it, where we can store it, where we can link it together and integrate it. It gives us the ability to analyze it and to visualize the insights from which we can then take action on as we move forward. So that's the vision and the mental model of what this perfect data might look like.